There is a substantial subgroup, roughly about a quarter of patients, who fall into a slower or less than ideal recovery group. So if this is happening to you, you're in very good company. The important part is that there is still room for things to get better. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle, and today we're digging into something that can be both annoying and worrying after knee replacement, and that's knee stiffness. If you're in that middle stretch of rehab where the swelling's better, but the knee still feels stubborn, this episode is meant to meet you right there. That tight, resistant feeling when you try to bend or straighten the joint can make you wonder if something went wrong or if you're already behind. By the end of this episode, you'll understand why stiffness happens in the first place, what typical motion progress looks like over the first few months, how strength and swelling tie into that tight feeling, what a structured rehab plan actually looks like, and what current research suggests for improving both knee bend and straightening. We'll also talk about how medical conditions like diabetes and your overall health habits influence your progress and what you can still do about it. Before we get into the mechanics of stiffness, I want to touch on something that often gets overlooked but makes a real difference, and that's prehab. A 2022 systematic review found that people who completed prehab entered surgery stronger and continued to function better in the early months afterward, essentially creating a smoother on-ramp into rehab. Starting stronger means stiffness feels less overwhelming. We'll revisit this later, but I want it on your radar from the start. A 2025 review by Orange and colleagues pulled together data from large cohort studies of people having knee replacement and tracked function for up to 5 years. They found that most people made their biggest gains in function between 3 and 6 months, then saw a small dip and a plateau after that. Performance-based tests like walking speed and timed stands often improved less than people's own rating of function, and in many cases didn't reach a clinically meaningful threshold at later time points. When you combine that with large rehab data sets, like the Minick and Capin work we'll talk about in a minute, you'll see a consistent pattern. There is a substantial subgroup, roughly about a quarter of patients, who fall into a slower or less than ideal recovery group. So if this is happening to you, you're in very good company. It's not strange, it's not rare, and it's not automatically a sign that something has gone off the rails. The important part is that there is still room for things to get better. Early stiffness is very much a normal response to a big event situation. Swelling inside the joint literally takes up space and makes bending harder. Inflammation makes the tissues feel more resistant. The quadriceps muscles often shut down temporarily when the knee joint is swollen. None of that means the implant is failing. It means your system is trying to figure out how to work with a new joint. A lot of people get about 100 to 110 degrees of bend by 6 weeks and close to full straightening. By 3 months, many reach 120 degrees or more. Some people are ahead of that, others are behind. These are common clinical benchmarks, not hard rules. Your specific targets may differ based on your surgery and medical history. Focus on the direction of change rather than comparing your numbers to anyone else's. In more than 12,000 patients studied by Minick and colleagues, people were divided in 2 groups, those receiving care guideline-based therapy and those receiving more variable care. The guideline emphasized early quadriceps activation, regular range of motion monitoring, swelling management, and progressive functional work. The early phase included swelling management, heel slides, gentle seated knee bends, quad sets, straight leg raises when appropriate, and short bouts of walking. Sit-to-stand work began from higher surfaces. Therapists also tracked progress with the knee outcome survey activities of daily living. As patients improved, training shifted toward functional loading and endurance, step-ups, longer walking times, more challenging sit-to-stands, and basic balance work. If motion lagged compared to expected ranges, the guideline emphasized more frequent motion work, not harder forcing of the motion. The guideline also highlighted ingredients that had been underused: structured education, progressive strengthening, balance training, and neuromuscular electrical stimulation, NMES, in the first 6 weeks when indicated. Capin and colleagues found that after guideline implementation, there was less variation in both outcomes and visit numbers. People were less dependent on which therapist or clinic they ended up with, more predictable outcomes, fewer poor results. And this is a good moment to zoom out. In real-world care, physical therapy isn't identical from clinic to clinic or even therapist to therapist. Research studies use strict inclusion criteria, which means many everyday patients, those with complex medical histories, slower early progress, or additional musculoskeletal issues, aren't fully represented in the study averages. So if your recovery doesn't match the typical curve perfectly, that doesn't mean you're off track. It means you're a whole person, not a filtered study sample. Physical therapy is still a central part of recovery, and your best guide is the care team that knows your surgery, your health history, and how your knee responds session to session. Bring your questions to them. They can help interpret the research in the context of your knee. When swelling is part of the problem, elevate your leg above heart level and do regular ankle pumps. That helps move fluid without stressing the knee. Short, frequent bending sessions beat long, painful ones. Manual joint mobilization is a common intervention in physical therapy and helps the joint surfaces move more smoothly, often making bending and straightening feel easier. If motion stays below 90 degrees of bend several months out and is affecting daily function, your surgeon may discuss manipulation under anesthesia, or MUA. Earlier manipulations, often within the first 3 months, tend to yield larger gains, though later ones can still help. We also covered this in more detail back in episode 12, so if you want a little deeper dive on how manipulation under anesthesia works and when it's considered, that episode is probably worth a listen. A 2021 review suggested that people with diabetes may experience more pain and functional limitations around the time of surgery, though the certainty of that evidence was somewhat low. What is clear is that steady routines, glucose control, activity, and strength work help the knee respond better over time. Better glucose management supports healing, reduces inflammation, and helps muscles work better. You don't need perfection, just consistent habits. And this ties directly into your movement patterns. A 2022 study by Duong and colleagues found that people who kept up with simple, reasonable step goals, not super long walks, just, regular movement, tended to build steadier activity habits over time. For anyone managing conditions like diabetes, these small, repeatable bouts of movement are often what make the biggest difference. Before we get into specifics of bending and straightening, it helps to know why these movements matter. Once swelling starts to settle and the quad begins to wake up, meaning the muscles begin to activate better, gentle, well-timed motion helps guide the knee back into its normal patterns without forcing it. These next exercises are examples of what your personal therapist might suggest to ease the joint into better range of motion. For knee bend, sit near the edge of the bed or chair and slowly slide your foot back. When you reach your best bend, pause there. Rest for a moment. Let the muscles soften and get used to the position of your knee. You might take a few deep breaths to help you relax and tell your body that it's okay. It's okay for your knee to be in that position. Then, gently coax a little more bend. And I say coax, not force. You can do this by sliding your heel back farther or keeping your foot touching the floor and safely scooting forward toward the edge of the seat. Then release. Repeat this a few times instead of forcing one big single push. For straightening, sit on the couch or bed and get your operated leg out straight. Rest your heel on a rolled towel so the knee hangs slightly. Gently tighten your quad so that the back of your knee gently falls down toward the flat surface. Even if the motion is small, the quad signal matters, helping your knee get used to being out straight. When a knee stays tight in the mid-rehab window, strength and motion usually improve together. Anything that helps the quad wake up tends to make the bending and straightening feel more possible. And that's exactly where neuromuscular electrical stimulation, or NMES, fits in. NMES uses electrical current to assist you in contracting that quadricep. That's the group of 4 muscles on the top of your thigh that control the knee. After knee replacement, the quad often struggles to activate because of arthrogenic inhibition. And that's your nervous system protecting the joint, and that makes the muscles take a hit. NMES helps to generate a stronger contraction than you can voluntarily produce early on. And here's what we know from the research. Systematic reviews suggest that when NMES is paired with exercise, people tend to gain more quadricep strength and see modest short-term improvements in both pain and function compared with exercise alone. Earlier, high-intensity use, especially in the first weeks after surgery, has actually been shown to preserve quadricep strength more effectively and to improve walking speed and timed up-and-go performance. Studies show that combined in-clinic and at-home NMES also demonstrated faster early strength gains and better functional test outcomes. The clinical commentary by Arhos and colleagues adds important nuance. For NMES to actually work the way it's intended, the muscle contraction has to be strong, often around half of what your quad can produce voluntarily. Achieving that typically requires larger electrodes and enough current to create a clear visible contraction. The goal is firm but tolerable intensity, not a light sensory buzz. They also emphasize that NMES should be used as an adjunct to exercise rather than a substitute, and that its benefits are most noticeable when it's introduced within the first 6 weeks after surgery. A typical NMES session includes several sets of 10 to 15 stronger contractions, with you tightening along with the stimulation, an approach consistent with the dosing parameters summarized in the Arhos clinical commentary from 2024. There are also times when NMES shouldn't be used. It's generally avoided over areas with any active infection, any open wounds, or poorly healed incisions. It's not generally used if you have a pacemaker or placed over implanted electrical devices, and it's not used when someone has uncontrolled seizures. Your therapist or medical team will screen for these situations, but it's always worth mentioning any implants, medical devices, or concerns so the setup stays both safe and effective. These general safety considerations are also outlined in the Arhos clinical commentary, and you can find the reference in the show notes. Most mid-rehab tightness, it tends to follow a predictable pattern, but there are a few situations where you should check in with your surgeon or medical team. Sudden increases in pain, warmth, or swelling that doesn't match your activity level. Significant loss of motion after you'd been making steady progress. Fever or chills, or a knee that feels unstable or gives out repeatedly. Those deserve attention. And these signs don't automatically mean something serious is wrong, but they're certainly worth a professional look. Here's a big picture to carry with you. Stiffness doesn't have the final say. It shifts as swelling settles. The quad wakes up, and the knee gets steady opportunities to move in the ranges it can tolerate. None of this requires heroic effort, just the kind of consistent, doable work that gradually changes how the knee behaves. Tools like NMES help when activation is hard, and the groundwork you build through prehab makes all of these pieces easier to manage. In episode 22, we'll take a deeper look at prehab, what it actually includes, who benefits the most, and how it sets the stage for smoother progress in those early weeks after surgery. It's a topic people say they'd wish they'd learned earlier, so we'll break it down clearly and practically. Thanks for joining me today. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.